So now we will talk about postpartum hemorrhage. Blood loss has the has, is postpartum hemorrhage is defined as a blood loss involving 5% of deliveries that has the potential to produce or produces an hemodynamic instability. Can be early or primary postpartum hemorrhage within 24 hours from delivery, late or secondary postpartum hemorrhage after 24 hours or more from delivery. Quantity can have in a vaginal delivery more than 500 milliliters of total blood loss. A cesarean delivery more than 1000 milliliters total blood loss. It's quite difficult to precisely quantify the amount of blood loss despite the use of special calibrated bags. Therefore, the clinical assessment in the end is more important than the quantity lost. Causes are atony, more than 90% of cases of postpartum hemorrhage, coagulopathy, retention of placental elements in the uterus, uterine inversion or rupture. Trauma may easily occur, especially within the genital tract during vaginal delivery, since sometimes it may pass undiagnosed, some unexpected bleeding may happen later. Prevention is important because postpartum hemorrhage is one of the most challenging situations to face, especially if it's severe. So avoid the genital trauma. The pushing phase of labor is crucial at the to minimize the genital trauma. Prophylactic drugs such as oxytocic agents at the onset of the third stage of labor in order to improve the contraction of the uterus after delivery of placenta. Actively manage the third stage of labor with controlled cord retraction after signs of placental separation have occurred. Forties that may cause postpartum hemorrhage. Tone, atony is the cause of more than 95% of cases. Tissue, retained tissues or clots. Trauma, lacerations, rupture, inversion. Thrombin, coagulopathy. So I said in prevention measures are avoid genital trauma, prophylactic drugs such as oxytocin agents, and actively manage the third stage of labor with controlled cord traction. Then we said the fourth is uterine atony. Diagnosis. The best defensive mechanism to minimize bleeding during labor is the contraction of the uterus. Therefore, you have to assess whether it's soft or contracting on abdominal examination. And in the case it's not contracting, you have to start the procedures to make it contract. The careful assessment of vaginal bleeding is one of the ways to prevent severe bleeding. Indeed, we place calibrated plastic bag under the bottom of the table to measure the quantity of loss, and as soon as the quantity of postpartum hemorrhage definition is reached, we have to start all the procedure to reduce the bleeding. Risk factors of uterine atony are uterine overdistension due to polyhydramnios, excessive amount of amniotic fluid, multiple gestation, fetal macrosomia. So keep everything ready to face any possible problem that may occur during or after delivery. Another risk factor is the use of oxytocin, which is administered to women to accelerate the dilating phase of labor or to support the second stage. Sometimes may also cause muscles to be unable to keep on contracting due to alterations in the receptors. Then we can have very quick or prolonged labor, high parity, choriamnionitis, or myometral relaxing agents like magnesium sulfate and anesthetic agents that may be used before or during labor to manage some concomitant clinical conditions. So here we have a table where say that we can have a blood volume loss between 500 and 1000 and the blood pressure is normal. The degree of shock is compensated between 1000 and 1500 milliliters, that is 15-25% of blood loss. We have a slight fall of blood pressure, the degree of shock is mild. We have weakness, tachycardia, and sweating. In case of 1500, 2000, we have moderate shock with a moderate fall of blood pressure. Signs are restlessness, pallor, oliguria. And when the blood volume loss is 2000-3000 milliliters, that is 35-50% of blood, we have a severe shock with marked fall of blood pressure, and collapse symptoms are collapse, air hunger, and anuria. Treatment: massage the uterus if you feel on abdominal examination that it isn't contracting. Bimanual uterine massage and compression between one end of the abdomen and one end on the abdomen and one in the vagina. One of the concomitant maneuvers to do in case of excessive bleeding is to put a soap mounted on a forceps into the vaginal canal to lift the uterus and to distend the vessels, to decrease the amount of bleeding coming from the uterus and massage the uterus itself. In many developing countries where drugs and advanced facilities are present, this is often used to reduce vaginal bleeding during delivery. Medications: oxytocin to make uterus contract and decrease amount of bleeding, no contraindications. High volume infused might have some side effects, and in that case we should decrease the infusion. Then methylergonovin, usually intramuscularly injected, contraindicated in hypotensive patients. Side effects: we have side effects. Supportive measures: we have adequate fluid resuscitation via 2 large bores IV that are 2 venous accesses at least to restore the circulating volume and to give drugs. Then replacement of blood products as needed, and anesthesia consultation in the event of emergent laparotomy is necessary. Surgery to stop bleeding: we can do a B-Lynch suture, which is a form of compression suture used in gynecology to mechanically compress an atonic uterus in the face of severe postpartum hemorrhage. It can stop postpartum hemorrhage without the need for pelvic surgery and potentially preserving fertility and the anatomical integrity of the uterus. It's a sort of double suture. Uterine artery ligation, not an easy procedure because the vessels may be congested and the artery won't be immediately identifiable with certainty. Can have genital tract trauma. In the case of postpartum hemorrhage, in about 7% of women, it's the case of postpartum hemorrhage, and in about 7% of women, and is the production of lacerations or hematoma during passage of baby along vaginal canal. Sometimes we can have hematoma that do not cause bleeding but stay hidden somehow in deeper tissue and can cause other problems such as infections or pain or functional impairment of muscles around. Risk factors are abnormal presentations. The most common one occurs when the head of the baby is in front of the face, the diameter is bigger, and the passage within the vaginal canal may cause damages. Operative delivery, the use of forceps or ventouse, and episiotomy. Sometimes the sutures aren't easy to do. It may occur also that the sutures aren't performed by specialists, so the risk increases for postpartum bleeding. We can have precipitous delivery, like a quick second stage mucous muscle tears, obstructed labor, fetal macrosomia. Overdistension of the vaginal canal may cause tears of muscles, and multiple gestation. So, risk factors repeat: abnormal presentations, operative delivery, episiotomy, precipitous delivery, obstructed labor, fetal macrosomia, multiple gestation. Clinical management. You can have bleeding from an episiotomy or perineal laceration is usually obvious, and prompt ligature will control the bleeding. Persistent bleeding without any retainment of placenta visible with a scan, with a contracted uterus, and especially after oxytocin has been administered, is strongly suggestive of genital tract lesions. Sometimes it's not the vaginal canal itself, but the neck of the uterus to be damaged part, with a resulting severe bleeding, which is hard to stop by suture, causing most of these cases to be carried in the operating room. This can happen either because of a mistake in the management in the second stage of labor, after the woman feels like to push, despite not being fully dilated, and those who assist her do not tell her to wait, or is not a mismanagement but a risk we take when the heart rate of the baby isn't reassuring, so we want to speed up and prefer to risk a bit. Exploration is best done under general anesthesia or continued epidural anesthesia. In the UK, any lesion that may involve the anal sphincter is accurately examined and brought to the operating room. Clinical findings can have significant bleeding in the absence of cervical, vaginal, or perineal tears, which is suggestive of uterine rupture even if there is response to oxytocin. Digital exploration of the uterus in case of C-section and difficult or complicated deliveries. Treatment: full thickness mucosal repair, beginning above the apex because bleeding vessels tend to retract, or continuous interlocking absorbable sutures is generally used. Use big sutures to be sure they will hold. When suturing in the proximity of the urethra, insertion of a catheter is advisable to avoid injury of this structure. A catheter should, by the way, be placed when severe hemorrhage occur, because it would allow women to rest for some time and let the sutured lesions to heal without the need of moving to go to the bathroom while she is still weak. You have also blood transfusion, antibiotics to prevent secondary infections. Retained placenta. Clinical manifestations are bleeding persists in the absence of apparent lacerations or atony because the contraction around the retained placenta is not effective, or the expelled placenta should be carefully inspected for completeness following each delivery. Risk factors of retained placenta are early cord traction attempts. It would be better to wait for the physiological delivery of the placenta to occur. Placenta creta, increta, and precreta, and subcenturiate lobe. When placenta invades to different degrees the myometrium. When the invasion of the muscular layer is very severe, more drastic measures such as laparotomy could be required. By the way, this is already known before the delivery because this condition is easily seen at scan. Placenta creta occurs in 1 out of 2,500 7,000 deliveries and consists of a relatively superficial attachment of the placenta to the myometrium. More invasive attachment, increta or pancreata, is less common. Predisposing factors. We can have previous postpartum curettage. The damage to the uterus may cause some scarring tissue to be abnormally attached lately by placenta. You can have cesarean delivery again may cause some scarring tissue to remain. Hysterectomy. When a cesarean section is performed before the 28th week of gestation, when the uterine thickness is much higher than a term, causing an even worse scarring reaction. You can have placenta previa, again the problem could be scarring. You have to suture the parts of the uterus where the placenta is coming down. Or we can have high parity. Treatment is done in this way. The best treatment for when you got high severe bleeding, strongly thought to be caused by placenta retention, is to perform a manual digital intrauterine exploration, and explore cavity to avoid further scarring using curettage. You try to explore and to pick up the retained placenta with the hand. In more severe cases, curettage is the only thing that can be done. Care must be taken to avoid uterine perforation when you need to perform curettage in the case of a placenta creta, increta, or precreta. The thickness of the uterus at term is higher than normal, and improper curettage may cause uterine perforation. When all these mechanisms are not feasible, laparotomy. Conservative surgical management with manual removal and packing can be attempted. If everything fails again, you should perform hysterectomy. In case of placental abnormalities, morbidity and mortality rates are high. Thrombosis and coagulopathy. It's important. It's important cause um, of uh, hemorrhage. Coagulopathies may be hereditary, such as hemophilia A, due to anticoagulant therapy, for example, when the patient had previous heart valve replacement or acquired during pregnancy. You can have thrombocytopenia, HELP syndrome, that is hemolysis, elevated liver enzymes, low platelet, systemic syndrome, and DIC, eclampsia, intrauterine fetal death, septicemia, placenta abrupte placentae, amniotic fluid embolism. One of the most important causes of uterine bleeding is uterine inversion. Unfortunately, it's quite a rare condition. It may happen either before or after placenta delivery. Abnormal abdominal examination reveals the uterine fundus to be inverted or missing. Vaginal inspection and examination confirm the diagnosis. There are 4 degrees of severity. Can have level 1, the fundus may be inverted above the cervix. Level 2, below the cervix but within the vagina. Level 3, outside the vagina. Level 4, the uterus and vagina may both be found outside the vulva. In levels 3 and 4, you should replace uterine anatomy. So level 1, fundus may be inverted above the cervix. Level 2, below the cervix but within the vagina. Level 3, outside the vagina. Level 4, uterus and vagina may be found outside the vulva. Risk factors are fundal placentation, fetal macrosomia, use of oxytocin, uterine anomalies, placenta creta. 50% of reported cases occur spontaneously in premiparous patients. Treatment is done by manual replacement of the uterus in the normal position. You should identify the fundus of the uterus and put it back in place while massaging it. Do not remove the end until the uterus is repositioned. This maneuver has a lot of side effects, among which vagal shock. Intrauterine volume replacement. Intravascular volume replacement. If the placenta has not been removed, replace the uterus by applying pressure to the inverted fundus without removing the placenta and increasing natural oxytocin. If manual replacement succeeds, the placenta can be manually removed. Uterine contractions assured by massage and oxytocin infusion. When all above measures fail, laparotomy is indicated to correct inversion with hysterectomy. Uterine rupture is an important cause of hemorrhage, but it usually occurs before delivery. Partial rupture of the uterus can occur even after birth. You can have clinical manifestations like tachycardia, shock, fetal distress, changes in ECG. The shape of the tummy completely changes. You can see the baby pushing, the fetal head comes up compared to the previous examination. You have this appearance of presenting part from the pelvis. You have also variable amount of pain and vaginal bleeding. Complete rupture involves the rupture of the visceral peritoneum and results in intraperitoneal bleeding. Incomplete rupture occurs when the visceral peritoneum remains intact over the ruptured myometrium. The risk factors are obstructed labor, multiple gestation, abnormal fetal lie, high parity, use of oxytocin, prostaglandins, spontaneous uterine hyperstimulation, internal podalic version, or breech extraction. Okay, treatment. Intravascular volume and blood replacement, immediate laparotomy, and with spontaneous rupture, 85% of patients require hysterectomy, whereas 65% of ruptured scars can be repaired. Late postpartum hemorrhage is defined as any sudden loss of any amount of flesh blood occurring after the first 24 hours of delivery and within 6 weeks postnatally. It may be due to retained placental tissue, subinvolution of the placental bed, endometritis, tender painful uterus with low contractility. Treatment. If the bleeding is not severe, antibiotics make a good first choice, and if bleeding persists, curettage should be implemented in order to take the remaining placenta out. Be careful when you perform curettage to avoid any further damage to the uterus. Puerperal infections. We have puerperal febrile morbidity, a temperature of 38, the temperature to occur in any two of the first 10 days postpartum, exclusive of the first 24 hours, and to be taken by mouth by standard technique at least 4 times daily. The overall rate of postpartum infection is estimated to be 1 to 8%. Transient low-grade fever is common in the postpartum period and will resolve spontaneously in the majority of patients who deliver vaginally. In patients who undergo cesarean delivery, only 30% of fevers will resolve spontaneously, reflecting the greater risk for development of infection after surgery. So we have a greater risk for development of infection after surgery. Risk factors are PROM, anemia, hemorrhage, episiotomy and C-section, and placenta retain. Physical examination focusing on lungs, breast, uterine fundus, abdomen for incision section, infections, perineum, lower extremities. Lab tests are complete blood count with differential, urinalysis with culture. Blood cultures may be considered, sputum for gram stain, and culture if respiratory infection is suspected. Treatment is done with nutrition, anemia prevention, antimicrobial treatment, so broad spectrum, high dose, long time, drainage, or treatment of thrombophlebitis. Immediate complications are anemia, hypovolemic shock, acute renal failure, acute liver failure, like hepatorenal syndrome, acute pulmonary edema, consumption coagulopathy, transfusion reactions, iatrogenic. Long-term complications are infections, puerperal infections, Sheehan syndrome, necrosis of anterior pituitary, that is the necrosis of anterior pituitary, chronic anemia, chronic renal failure. Infertility, Asherman syndrome, condition characterized by the presence of adhesions and or fibrosis within the uterine cavity due to scars, tubal obstruction, secondary to infections, post-hysterectomy. So the infertility can be due to Asherman syndrome or tubal obstruction, secondary to infections or post-hysterectomy.